Welcome everyone to our Lunch and Learn for September. We'll be talking about perinatal mental health with Molly Martin, who is a licensed social worker, and she practices at MWR Counseling in Hiawatha. She provides therapy to individuals with a focus on the mind-body connection to treat anxiety, depression, PTSD, insomnia, and life transitions, including those experienced during the perinatal period. Polly is certified in EMDR, or eye movement desensitization reprocessing, and has additional training and experience in the treatment of maternal mental health, insomnia, sensory intervention, and collaborative problem solving. In addition to individual therapy, Molly provides clinical and administrative supervision to clinicians pursuing independent licensure. So welcome, Molly. Welcome, all of you. We are recording this to put on our YouTube channel. So let's go. Let's tell us a little bit about yourself, Molly.
Yes, yeah, thank you for the introduction. I am a clinician and the program director here at MWR. And prior to working here, I spent a lot of time working with kids and families. And when I moved over to MWR, I was talking with one of the co-owners here who does a lot of perinatal work. And she had asked if I had any interest in this. And at the time, I didn't even know that this was an area that you could focus on, but was really, really interested in it. I have a few young children of my own, and so having gone through some of those adjustments that come with pregnancy and postpartum, found that really interesting. And so, a sense, have done additional trainings, readings, consultation, and continued work with the perinatal population. So, today, I think what we'll do is kind of give a pretty broad overview of perinatal mental health and working with people who are experiencing challenges in this area. And as we are going along, if there are questions that come up, please feel free to ask those as we go, or if there are areas that we want to get more in depth in, or don't need to go quite as in depth in, we can be really flexible to that. So I would encourage anyone to just speak up as we get going here. So we're doing an introduction to perinatal mental health. And the first thing I want to speak on before we get started here is a recognition of some of the language that we'll use throughout our presentation today. Perinatal mental health can affect a really broad range of people, and usually specifically we're looking at parents as they're going through that transition around childbirth, infancy, and beyond. And certainly can affect mothers, fathers, birthing parents, non-birthing parents. For the purposes of what we're doing today, with the time that we have today, our focus is really going to be a lot on the birthing person, because there are specific hormonal impacts, certain physical impacts that are specific to that person. And that's not to exclude any other parents or individuals who are experiencing any perinatal mental health needs, but that we want to be able to get through the information that is maybe most often presenting as we're going along. There are going to be a few times, and you can actually see right here on this first page, that the terms woman, the pronouns she and her are being used throughout. And when you see that, there are direct quotes, and there's also direct data that I'm taking from other sources. And so I'm going to use the language that was used within that documentation. But otherwise, we'll often be referring to mothers and to the birthing person and the impacts of some of these changes on that person specifically. And so as we get started and we're looking at, okay, well, so what is maternal mental health? And this comes from the World Health Organization, that it's a state of well-being in which a mother realizes her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to her community. So that's kind of the ideal, right, is to be able to live in that state of mental health. But we also know that a lot of people experience what we call perinatal mood and anxiety disorders. And so this is a really broad term that encompasses any of those disorders that can take place during pregnancy and really through that first year after a person gives birth. Um, Prenatal and postpartum can also be used interchangeably. And for anyone who is working in and specializing in this area, the period of trying to conceive can also be included in that perinatal timeframe definition. So prenatal being that time during pregnancy, and then postpartum or postnatal being that time after pregnancy in that first postpartum year. So we want to start out with just kind of looking at what are some of the facts and figures that we are aware of and the impacts that it has on people. Every year, it's more than 400,000 infants born to mothers who are depressed. And with that knowledge, it makes perinatal depression the most underdiagnosed obstetric complication in America. And when we have people who are experiencing a postpartum depression, there are a lot of ongoing effects of that. So, increased costs of medical care, inappropriate medical care, child abuse and neglect, discontinuation of breastfeeding, family dysfunction, and having adverse effects on early brain development. So that can be really pretty widespread. And so we want to make sure that it's an area that we're really paying attention to and that we are able to do some effective intervention with. Some additional statistics here. So again, it's the most common complication of childbirth is the perinatal depression. Affects 15 to 20% of all perinatal women, and 1 out of 7 have depression in that year after they give birth. Mothers in lower socioeconomic areas are twice as likely to develop those depressive symptoms. And more recently, it seems that postpartum anxiety may actually be more prevalent than postpartum depression. Um, a, a challenge for that is only about 50% of women who are referred for treatment actually go through and follow up and receive that treatment. So it's happening a little bit more broadly, widespread than we're actually able to treat for it right now. And so the more that we can bring some awareness to it, the more that we can normalize some of the things that people are experiencing, the more we can improve access to care so that there's a greater number of people who are being affected who are able to access treatment. And then this last one here, in the first few weeks after delivery, a woman's chance of requiring a psychiatric admission is 7 times higher than at any other time in her life. And so this is a really delicate time of life. There's a lot of changes. There's a lot of factors that are going into the experiences and the responses that an individual is having. And so being able to provide specific treatment in this area is really, really valuable, both for the individual who is experiencing those mental health conditions, but also for the relationships that they're in, the infants or the children that are being affected by it as well. And so treatment of that one person really has the potential to have positive effects in other areas as well. And so when we're talking about perinatal mood and anxiety disorders, postpartum depression is kind of the commonly used term that we think of when somebody is experiencing some shifts in mood and functioning during the postpartum period. But perinatal mood and anxiety disorders are actually a number of different conditions that all fall under this PMADs, perinatal mood and anxiety disorders realm. And so we've got postpartum depression, which tends to be the one that people are most familiar with. There's also postpartum anxiety, postpartum OCD, postpartum PTSD, postpartum psychosis, postpartum bipolar. And then I didn't include on here, but there's also postpartum panic, and that has a lot of overlap with postpartum anxiety. And so again, with the time we have today, didn't speak specifically to that. And then a postpartum adjustment, which is all of the changes that are going on in life in that postpartum period, and not necessarily meeting criteria for any of these disorders, but that is having an impact on well-being and functioning. So I'm going to come back in a little bit to the 6 of these mood and anxiety disorders, and we'll talk about them in a little bit more detail. But I want to start with looking at some common presenting concerns. So again, those PMADs, the perinatal mood and anxiety disorders. In addition to that, perinatal loss. So anyone who's working with the perinatal population is likely going to encounter individuals who have experienced miscarriages, stillbirths, or termination, and termination which either can be elective or for medical reasons. There's birth trauma, challenges with fertility, relationships issues between couples, and then really pretty common but sometimes overlooked one is any family of origin or attachment wounds, that as somebody is becoming a parent, we kind of simultaneously can go back through our own experiences and start noticing things that we needed but didn't have, or things that happened that continue to have an effect on us. And so that can come up and can contribute to our overall well-being in that transition into parenthood as well. There are a number of risk factors that can come up when a person is going through the postpartum or perinatal period that might make it more likely that they would develop one of those conditions. So having a prior history, if somebody has previously experienced postpartum depression or anxiety or any of those other conditions, they have a greater likelihood of experiencing it again with future pregnancies and deliveries. If there's a personal or a family history of any of those conditions, and so if perhaps their own mother experienced that, it might make it more likely that a person is going to experience it themselves. Anyone who has a history of hormonal mood disorders, so this would be things like PMS, PMDD, or having reactions to hormonal birth control, because there are a lot of hormonal interactions that are going on during pregnancy and the postpartum period that can impact how people are responding to those changes. History of eating disorders, history of self-harm, any endocrine dysfunction, so thyroid disease, diabetes. Certainly we know that with a number of physical health conditions, there are impacts on mental well-being as well. And so looking into the presence of any of those conditions and being aware of how those might impact mental health as well is an important consideration. Anyone who has any unresolved losses, particularly if they are reproductive in nature. So if there's been a history of miscarriages, infertility, abortion, then that may impact the person's well-being during that pregnancy and postpartum period. Any history of abuse or any current significant stressors, illnesses, divorce, moving, work stressors, anything like that that is impacting day-to-day functioning. Some personal characteristics, so having a perfectionistic personality or a high need for control or achievement can be really challenging during the postpartum period because babies are pretty unpredictable, and there's a lot that goes on with them that we're not able to control, and so that can certainly create some challenges as well. And then things that are going on potentially with baby, having a challenging baby, having a baby who is colicky, that has high needs, that experienced an illness or injury, or any developmental delays adds to the stress level and can impact the caregiver's overall well-being. In addition, having multiple births, so twins, triplets, or more, can certainly add to the stress level as well. Having an infant who needs to be in the NICU following birth, really for any length of time. Having a traumatic or a disappointing birth can be a risk factor for developing PMADs. Any breastfeeding issues, when breastfeeding goals maybe don't align with breastfeeding outcome, or ongoing challenges related to feeding, related to baby's weight gain that can cause stress. And then there's social factors. Anyone who feels maybe socially isolated, has a poor social support system, if there's financial difficulties, that contributes, and then teen pregnancies as well. So any of these things that are going on would make it more likely that a person would be experiencing some impairment in functioning and some symptoms that might indicate that there is perinatal mood or anxiety disorder going on for them. In addition, there's a few exacerbating factors. So pain, certainly if somebody is healing from childbirth, that impacts their overall well-being. Sometimes there's pain with breastfeeding, that can be a factor as well. Lack of sleep, which is really pretty common during the postpartum period. And this is true for nearly all mental health conditions. Sleep is foundational for our overall well being. And so when we're put into a period of time where there's lack of sleep, when you're able to get sleep, might feel very out of your control, and that it's unpredictable how long that's going to last. That can certainly have an impact on how we're feeling. Abrupt discontinuation of breastfeeding can be a factor, and there's a lot that can be kind of tied up with breastfeeding and how people are feeling and responding to it. So, as I mentioned a moment ago, expectations versus reality, disappointment. Can certainly be a factor, but specifically here with the abrupt discontinuation, there is kind of just a cascade of hormonal responses that can come in when breastfeeding is stopped very suddenly. And so that can have an impact on overall well-being when we're managing those hormonal changes. Childcare stress, marital stress, things that are going on in the environment that are increasing stress levels, and then sometimes if there's a shift between, role professionally, role in career, and then a shift to role as a mother, and trying to kind of balance out what are the values, what are the goals, and how are competing maybe demands or competing needs being met. That can all contribute as well. Take a moment and we're going to talk about baby blues. And baby blues is this period of time postpartum that is really, really very common. Most women experience time period where they would meet some of this criteria of being in the baby blues. It is related to hormonal shifts that are occurring in that first, usually week or two postpartum, so immediately after birth. Baby blues is not the same as postpartum depression. They do share similar features, but there are some differences in it. With baby blues, it tends to be pretty mild, it tends to be transient. It's not an ongoing way that they're continuing to respond to their emotional needs. It's a pretty common feature, and it's self-limiting. It doesn't typically require treatment. So again, it's within typically about that 2 weeks postpartum when the hormonal shifts are really kind of working to stabilize there a bit. And so what we see is weepiness, sadness, forgetfulness, a feeling of being overwhelmed, generally just feeling pretty emotional, pretty anxious or fatigued. And for most people, those feelings are pretty uneventful. Nothing really happens from them and pretty fleeting. They come and go. When we're assessing for, is this a pretty normal transient baby blues, or is this postpartum depression or something else? We're really going to be looking at what's the frequency, the severity, and the duration of those symptoms. So frequency, is this happening all day, every day, or does it come and go? Is it occasional? Does it kind of come in some waves and then decrease? Severity, if we're thinking about on a scale of 0 to 10, if it's, oh, felt kind of sad, felt kind of weepy, and it was a 3 or it was a 4, versus an 8, 9, 10, that it's really, really intense. And the baby blues are going to tend to be a little bit less intense. And then the duration, again, it's around about 2 weeks postpartum. So if I have somebody who's coming in and they're 6 months postpartum and things were fine, and now they're experiencing these symptoms, that to me is more likely indicating postpartum depression than a typical kind of baby blues adjustment period. Okay, so when we are diagnosing, and I've got 3 on this slide, and there's gonna be 3 on the next. So can I outline there are those 6 conditions: depression, anxiety, OCD, PTSD, psychosis, and bipolar. And so these are those PMADs conditions that we would look at diagnosing either during pregnancy or postpartum during that first year or so postpartum. And so, starting out here with depression, postpartum depression, again, is probably the most commonly known diagnosis associated with the perinatal period. And a lot of the symptoms look pretty typical or pretty similar to a typical depression. So, there might be anger, irritability, disturbances or changes in sleep, disturbances or changes in appetite, sadness or crying. And sometimes that's happening, but for other people, it can be that lack of feeling pleasure, feeling happiness, lack of feeling positive emotions that is more prevalent when experiencing depression. Feeling overwhelmed, feelings of guilt tend to be associated with depression quite a bit. And sometimes it's that numbness and emptiness and just feeling very disconnected as well. But in addition, when it is specific to that perinatal period, there can also be a lack of interest in the baby or difficult bonding with the baby. And so feeling kind of disconnected from baby during this time that bonding is really important, and that bonding feels like something that people are often naturally drawn to do. So when that's not happening, that might be a sign that some assessment and possible treatment would be helpful. There can be thoughts of harming baby that come up with postpartum depression, and I'm going to talk a little bit more about that in a moment here. And there can be suicidal thoughts that come along with depression as well. And postpartum or perinatal depression tends to affect about 1 in 7 people during pregnancy or postpartum. Anxiety, similar thing. Postpartum or perinatal anxiety, in some ways, it's going to look very similar to a generalized anxiety. There might be tension, irritability, constantly on the go, constantly need to be doing. That sense of dread, just something bad is going to happen. Um, Frequent worries, feeling very restless, feeling on edge. And then specifically with baby, sometimes people will experience or will verbalize a sense of being afraid of being alone with baby. So if they are really concerned about their ability to take care of baby, their ability to keep baby safe, their ability to respond to stressors that come up when they're the only one who's there. And often then we'll engage in some reassurance seeking behaviors. And so it might be checking in repeatedly with a pediatrician, checking in repeatedly with their own doctor, checking in with a partner, a spouse, a parent, a friend, and am I doing this right? Is this how this should be? So constantly kind of asking those questions and wanting the reassurance that what they're doing really is okay. And there can be a lot of physical symptoms that come up with the anxiety as well. And this tends to affect about 11 to 21% of people during pregnancy or postpartum. Looking then at perinatal OCD, so OCD is going to be a cycle of obsessions and compulsions. The obsessions are those unwanted thoughts, they're images, they're intrusive, and they're occurring repeatedly and are outside of a person's control, and really cause a great deal of distress to experience those ongoing and intrusive symptoms. And so to deal with that, we engage in compulsions, which are repetitive behaviors or thoughts that somebody is using to avoid or to decrease or to minimize the impact of those obsessions. OCD can present in a lot of different ways. Culturally, I think the most commonly known form of OCD is going to be a contamination OCD, right? That it's related to germs. I need to wash, I need to rewash, need to make sure that everything's clean, not need to make sure that there's not contamination. But with OCD, there's a really broad range of ways that it can present. And with perinatal OCD, some of those ways are related to harm, which is a lot of times about harm coming to the baby. And that can look like intrusive images or intrusive thoughts about harms that could come to them. Or in some cases, it's about the mother or the caregiver actually themselves causing that harm. So either that in some way baby's being harmed or that they themselves are causing harm to their baby. There can be concerns about losing control. Perfectionism can tend to feed into that. And then sometimes those intrusive thoughts are sexual in nature, which can feel really, really distressing for people, as it doesn't feel like it matches up with the way that they're feeling about their baby. This is less prevalent than depression and anxiety. It affects about 3 to 5% of people. But the intrusive thoughts that often accompany OCD actually happens in about, there's a broad range, 70 to 100% of new mothers experience some intrusive thoughts. And the reason for that is changes that are occurring in our brains during pregnancy and in the postpartum period, which makes us very aware of and very responsive to potential dangers. So it's a really adaptive response that has developed to maintain safety of our offspring. But sometimes it can get a bit intense. Things can go, feel like it goes a little bit haywire, and those thoughts become really frequent, really intense, and sometimes focused on some really, really distressing content that'll come up. I'm going to come back a little bit to OCD here in a future slide. So we'll talk a little bit more about that, but I'm going to go ahead and shift here to PTSD. So perinatal PTSD, very often related to birth trauma, can occur if there's a prolapsed cord, if there was an unplanned C-section, or if baby needed to have any time in the NICU for any complications that they had, as well as birthing complications. So hemorrhaging, preeclampsia, perineal trauma, if the epidural wasn't working. So anything that was progressing throughout the labor and delivery process that was really challenging to deal with or traumatic. Perinatal loss, so again, miscarriages, stillbirths, or termination can also be a traumatic experience for people to go through. And PTSD affects about 3 to 15% of people during the perinatal period. Perinatal psychosis is a really serious diagnosis, and it is often misrepresented as postpartum depression. So I'm going to again talk about this one specifically a little bit more here in a moment. But there's a lot of misunderstanding around perinatal psychosis, and so we want to spend just a little bit more time on getting some clarity around the differential diagnosis with it. But when a psychosis does happen, it tends to be a pretty sudden onset, usually within the first 2 weeks following birth, not always, but very often within that first 2 weeks following birth. When psychosis happens, this is a medical emergency. We want to make sure that anyone who's experiencing perinatal psychosis is getting help and support and assistance right away, because it is involving delusions, strange beliefs, hallucinations. They're often very irritated or agitated, might feel hyperactive, might have a lower need for sleep, might feel paranoid and have rapid mood swings. And some of the thoughts and behaviors that can come up around psychosis can present some pretty significant safety risks, both to the mother as well as to the child. This is a pretty rare condition. It occurs in 0.1 to 0.2% of births. So it's not very often that it's occurring, but it is something that we want to take really seriously when those symptoms are present. And then looking at perinatal bipolar, this is going to mimic a lot of the symptoms that we typically see in bipolar. So those patterns of depressive episodes, and then either manic, mixed, or hypomanic episodes. Um, the agitation, inflated self-esteem, flight of ideas, being very talkative, and increasing the goal-directed activity that often comes with those manic, mixed, or hypomanic episodes. The thing that's important to note on perinatal bipolar is that if somebody has a diagnosis of bipolar prior to pregnancy or postpartum, they are significantly more likely to have a recurrent episode, particularly if they stop medication during pregnancy or during the postpartum period. If there is no history, it's a much lower chance, it's a 2.6% for those who don't have any history of bipolar, but a high risk of those symptoms reemerging during pregnancy or postpartum, particularly if it is not effectively treated. Okay, so I want to come back a little bit and really address. I did OCD and psychosis on here, and I think we could kind of loop postpartum depression in as well. There's some overlap between these diagnoses, and so it's really, really important for providers to have a clear understanding of the similarities, but also the differences to ensure that we're providing number one, appropriate care, but also that we are challenging any barriers to care because of misunderstandings that can come up when these are not clearly defined. So, as I said earlier, postpartum psychosis is often referred to in the media as postpartum depression. And so, when we have some of these really high-profile cases that we see in the news, and they're really just heartbreaking situations, really, really terrible stories, and with infants or children who are being hurt, or in some cases, who are being killed. And when this is presented in the media as postpartum depression, it can create a lot of panic because postpartum psychosis is very rare. Postpartum depression is a lot more common. And so when people are showing signs of postpartum depression, if that's connected to, oh my goodness, now here's what might happen, it's not a narrative that is accurate, but it does create a lot of fear, and it does create sometimes a lot of fear in seeking help then. Um, and so looking specifically here at postpartum OCD and postpartum psychosis. So psychosis is often referred to as depression in the media, but the characteristics, it shares less with depression and more with postpartum OCD. And the main thing is that both of these can involve violent thoughts and images. So violent thoughts and images specific to causing harm to themselves or causing harm to baby. It sounds very concerning when somebody comes in and says, I had this image of doing this thing to my baby. And of course, we want to protect people, and we want to protect babies, and we want to protect kids. And so if we don't have a clear understanding of the differences between these, our response can be really inappropriate to what the needs of that mother really are. Because when a person is experiencing postpartum OCD, there's a very low risk of harm to that baby. When they are experiencing postpartum psychosis, there is a very high risk of harm to the baby. And so we want to act very quickly and have some specific plans in place when there are symptoms of that postpartum psychosis that's going up to make sure that we're maintaining safety, both for mom and for baby. But when we've got somebody who has postpartum OCD and that risk is really low, we have a much different approach to that. And one of the main differences that comes up, and as we're assessing this, things that we're looking for that help to differentiate between it is those violent thoughts and those violent images that can come up with postpartum OCD. Mom knows that those are wrong. Mom is usually really distressed about those. Mom is saying things like, I can't believe I'm thinking this. I would never do it. I would never harm my baby. Why can't I stop thinking about it? So these thoughts are really ego dystonic. They don't align with the thoughts, the beliefs, the goals, the values of that individual. And very often, the compulsions are focused around taking steps to protect baby. And so, not having things that could potentially result in those violent thoughts or images coming true. With postpartum psychosis, those delusional beliefs are egosyntonic. They feel very aligned with what mom is thinking in that moment. And so instead of feeling distressed about I'm feeling or I'm having these thoughts or I'm having these images and I would never do it, it's more along the lines of I'm having these thoughts, I'm having these images, and this is something that I should be acting on. So that behavior can look bizarre, it can look violent. And typically, when we are seeing those kind of high profile cases that are in the news, um, and I can't comment on every case, and certainly not appropriate to diagnose anyone based on a news story. But if you look into some of those, it's actually postpartum psychosis that those individuals most often are experiencing that is resulting in harm or death. And so that is why that's a medical emergency. It's something that we want to have an immediate and rapid response to. But that if somebody's experiencing and is reporting symptoms that align more with the postpartum OCD, that we can be working on a treatment plan over the course of weeks, over the course of months, and recognize that there's a very, very low risk of harm to baby. And in knowing this distinction, it is a barrier to people accessing care if they are feeling like, if I tell my doctor, if I tell the pediatrician, if I tell anybody I'm having these thoughts, they're going to take my baby away from me. They're going to put me in the hospital. And so sometimes people keep it very, very quiet and don't tell people that that is what they're experiencing. But if we know, hey, these thoughts are ego dystonic, you're not very likely going to act on these thoughts, then you can stay home with your baby and we can work on some OCD specific treatment to help to reduce the intensity and reduce the frequency of those thoughts and images and help you to take actions that do feel aligned with what your values and your goals are. So for screening, it is pretty simple to screen for a lot of PMADs, and it's a really good idea for providers to be screening. And that's because, as you've seen, it's a fairly high prevalence rate. And so when you are working with somebody who potentially could have one of these conditions, being able to screen for it and then have the person engage in some pretty effective and readily available treatments is a positive outcome for most people involved. Healthcare professionals that would have contact with pregnant or postpartum people and should be engaging in regular screening include PCPs, OBGYNs, pediatricians, ARNPs and PAs, any mental health professionals, lactation specialists, doulas, people working in WIC programs and in hospitals. And if we can go through some screening tools and get some information, they're not diagnostic, but can give enough information to indicate, hey, let's get you set up with a mental health professional trained in this area for further assessment, evaluation, diagnosis, and treatment. There are multiple screening tools that we can use, and I'm going to talk just about the first one here, the EPDS, but for your information that there are several other tools that are available. But the EPDS is a great tool to use. It has a lot of advantages. It's 10 questions. It's pretty quick and simple. It's available for free. It's specific to the perinatal time period. It's been validated with a variety of cultures. You can use it over the phone, and it's really easy to administer and to score. It doesn't link specifically to any diagnostic criteria, but can give you that again, that it's a screening tool to determine if additional assessment and treatment would be beneficial. Again, this is blurry, so you can't quite see it, but there are 10 questions in the EPDS that are really looking at depressive symptoms. And the final question on there asks about harm to self or others. And so if that is answered yes, we want to engage in risk assessment with that client to get more information and determine if we need to engage in any safety planning. But this can be helpful to also kind of see some changes over time as somebody's going through pregnancy and the postpartum period. Postpartum Support International recommends that mothers complete the EPDS at that first prenatal visit, once during the second trimester, once during the third trimester, at their 6-week follow-up, and then again at pediatric visits that pediatricians are utilizing that as well, because the symptoms can start really at any point in time, during pregnancy as well as that year postpartum. So we don't necessarily want it to be a one and done. We want to be looking over the entire time period that somebody might be affected to see how those scores might be changing and if there's areas of concerns that are coming up. Additional ways that we can assess is having mothers bring their babies into sessions or appointments with them. And this creates access to care in a number of ways. One is that a lot of new mothers might have some anxiety about being away from, separating from baby. And so being able to bring them along makes it easier to get to appointments. It also is helpful for people who might not have access to childcare, if they are on leave or if they're a stay-at-home parent, then being able to come to the appointment and bring their baby along can help them be able to access those services as well. And then also just in watching moms and babies, it's a really great assessment tool. So if you have a mom who's feeling depressed and is not very responsive to her baby, we can see that in real time and kind of talk about how much is this coming up and what's feeling normal and what are some of the things that we can do to start to address that. We do also want to rule out any potential medical causes for any of those conditions. And again, that can include thyroid dysfunction, deficiencies in iron or vitamin D, experiencing trauma, having side effects from any other medications, and substance use as well. And so when these symptoms are happening and we've gone through the assessment process and now we want to step in to begin treatment, we want to start out with having awareness of potential barriers. That can include if there's a denial of those symptoms. So for example, if a mother's experiencing anxiety but feels like that's very normal. I'm just being a good mom. I'm taking care of this and I'm checking that and I'm doing all of the things and that's a good thing. The inability to mobilize self. So this is maybe particularly with depression. If it is really difficult to get the energy and to get the motivation to take some of those initial steps, that can be challenging. Having an unsupportive partner, feeling like I don't have time or it's too intense. I need it to be fixed here just right away. Pressure from family or from social expectations. Cost of treatment can be a barrier, certainly. Feeling geographically isolated, not recognizing some of those symptoms that are going on, considering this to be, kind of that baby blues or normal adjustment, that they're going through some of those changes. stigma that can be involved in it. And then similar to what I spoke about with the OCD and psychosis, fear of being labeled a bad mother and fear of baby being taken away. If I say I'm having these thoughts, I'm not going to be able to keep baby with me. And so those are all things that can be a barrier that we want to have awareness of as we're looking at how are we setting up and making services available.
Yeah, and I think underlying all of that is just that shame, that idea that, I'm supposed to be so happy. This is supposed to be the best thing that ever happened to me. And why do I feel like this? But yeah, that
Such a good point.
need.
Yes. And so really managing that in isolation and feeling like I'm the only one that feels this way when we can see that's not true. But if we're not speaking about it and open about the reality of the experience, then it does feel, yes, very isolating and experiencing that shame. Yeah, thank you. So approaches to treatment, individual, couples, family, group counseling, support groups, having mom and baby together, and then psychopharmacology can be helpful. And when we're starting treatment, we want to gather information about the client's interpretation of that problem. We want to provide psychoeducation, which is a lot of the information that I've provided with you guys today. If they are interested in medication, providing a referral to meet with a prescribing doctor. We work a lot on practical strategies to address and alleviate symptoms. So, what are some of the day to day small actions, small steps that you can take to start to work through some of those symptoms that are feeling bothersome? Groups can be really helpful, and then coordinating together with an individual's physician on their care can be helpful as well. When we are engaging in treatment, we really want to be aware of the potential risk versus the potential benefit. And so this is a really wide topic, and we could spend a lot more time on it. But a simple example is I mentioned with postpartum bipolar, that when that is left untreated, the risk of recurrent symptoms is significantly high in the 70% that those symptoms will return. And so sometimes with a lot of medication intervention during pregnancy and postpartum, if someone is choosing to breastfeed, uh, there can be a sense of I don't want to put anything in my body because I'm not sure how it will affect baby. But we want to consider that it's a risk. If it's untreated depression, if it's untreated bipolar, there are risks to that as well. And so it's not only the risk involved with any medication that you take, but also what is the risk to your overall well-being and to baby's well-being if it is left untreated. Um, so there are those pharmacological strategies for moderate to severe symptoms, often used in conjunction with other therapies. We recognize that some symptoms respond better to medication than others. And because there's a lot of misinformation about medication during pregnancy and lactation, there are some really wonderful resources that provide up to date research and recommendations on um, medication management during pregnancy and postpartum. And among them, I've got a few listed here. The one at the bottom, PSI has a perinatal psychiatric consult line. And so I'm not a prescriber, I'm not a doctor, so I wouldn't tell somebody what medication they should or could take. But if they're talking to their doctor, to their prescriber, and that prescriber just does not have a lot of information about prescribing during pregnancy and lactation, this hotline is for prescribers to talk to other prescribers who do specialize in this, and so that they can have a free consultation to help to make some of those decisions when looking at prescribing during that period of life. There are also complementary and alternative therapies that can be used, including acupuncture, bright light therapy, hypnosis, omega-3 fatty acids, exercise, relaxation techniques, and massage therapy as well. And so for some people, having kind of a comprehensive, holistic approach can be really helpful in managing the symptoms that are coming up for them. And then in terms of therapeutic intervention, again, we do a lot of practical planning and problem solving. And so, really looking at kind of day to day, what things are working, what things aren't working, what things can we put in place in terms of support systems, structure, schedules, coping tools, and some of those things to help day to day feel a little bit more manageable. We really are focusing initially, at least, on symptom relief first. So it's not typically a type of therapy where we're looking back at, oh, well, what happened when you were a child that's making this hard right now? It's what do we need to do immediately that will help this to feel more manageable. Practicing the art of holding in therapy and really holding that space um, for moms as they're going through that transition. CBT techniques, ACT, DBT, ERP, mindfulness, and somatic regulation are all therapy approaches that can be really, really helpful and effective in managing symptoms of PMADs. And I've got sleep in all caps with an exclamation point because sleep is a legitimate a chemical intervention. As I said before, it's foundational for all mental health and well-being, and it's not happening a lot during the postpartum period. And so, if we can look at developing some plans around, is there a partner that can be supportive? Are there opportunities to structure sleep in a way that it's typically a chunk of 3 hours twice in a 24-hour period um, is what most adults need to feel like they're able to complete their sleep cycles and be able to feel rested. And so we're not necessarily setting a plan for, hey, how do we get you 8 hours tonight when you've got a baby that is up several times? But is there a way that we can structure, hey, you did get 3 hours here, and here's another opportunity that you can get 3 hours again, so that in that transition time period, you're getting sleep that does help you to be able to meet the other demands that are going on in life. I know we're getting to the end of our time, so I'm kind of rushing through these last few slides here. There are risks involved with not treating these perinatal mood and anxiety disorders. And so for the mother, quality of life is a significant impact. Their ability to function at home or at work is certainly impacted. It creates a risk of recurrent depression, and then suicide as well is a risk. But then those risks move out beyond the mother. And so for an infant who has a parent with PMADs without treatment, there can be an impact on the attachment that they're able to develop, depending on how that mother's symptoms are impacting their interactions with the infant. And then that can interfere with cognitive development as well. And then just in general in the family, it's a higher level of stress, higher level of conflict. If functioning at work is impacted, that can lead to loss of job, impacts on family income, as well as the time and the energy that's available to care for other children. And so it really can start to impact the entire family. And so if we're encountering mothers during this perinatal time period and can engage in the screening and can make referrals and can really reduce some of those barriers to treatment, then these are risks that we're able to really address and overcome and really improve functioning, both for mom as well as for baby and for other family members as well.
Molly, I'm struck by remembering a video that I saw where a baby was in a high chair and the mother was interacting and showing that serve and return.
Yes, yeah, the still fates experiment.
Right. And the baby's
Yeah.
laughing and the mom's laughing and singing. And then the same mother leaves the room and comes back, and the baby is ready to re-engage at that level, right? And laughing and smiling. But the mother, keeps her face very solemn.
Mhm.
And it's heartbreaking to watch that baby begin to just show apathy, the
How
baby,
quickly the
how
distress.
quickly
Yeah.
that goes, and you don't think about that as really a mother when you're just trying to get things done, and you're just, trying to do your daily meet the daily needs, and you're not smiling and you're not engaging, and what that can do to that baby's development. And
Yeah.
I just remember being so struck by that.
It's a tough to watch video because you just want to, scoop the baby up and give some interaction.
Right.
I do want to speak, and so that's called the still face experiment if anyone's interested in watching it. But on the flip side of that, there also has been research by it's Winnicott on the concept of being the good enough mother. And so sometimes some of the anxiety that develops is because I always have to be responsive. I always have to have that, right? And I don't have that to give. And what they found in this study and looking at the good enough mother is it's actually about 30%. If you can be, if when your baby has a need, your child has a need, and you're responding to it, we tend to get it right about 30% of the time. And that is good enough. That is good for babies and infants because their needs are being met. We're being responsive to their needs. If we don't get it right, we try again. But it really helps with development over time because um, that's kind of life, right? Is that we don't always accurately interpret what's going on. And so that's how we're developing healthy communication and healthy relationships is that sometimes we're going to get it right and sometimes we're going to get it wrong and we got to work through it. And so, yeah, it's kind of a balance between that where it's we want to be really responsive to the babies and we also want to have some grace around you're not going to get it right every time and you can
It'd be
still
perfect.
be really good mother, even though it's not always exactly right.
Yeah, it's so much more than we ever think about, right? All of
Yes. Yeah.
this, right? And we tend to think of just postpartum depression, and this is so much bigger.
Hmm.
Mhm.
Yeah. Yeah.
Any more questions?
I just wanted to say thank you, Molly, so much for this presentation. It resonated with me really on a personal level. I had extreme mental health challenges after my oldest daughter was born. And it makes so much sense now when you listed the risk factors at the beginning. I had almost all of them. So it was really validating for me to know like it wasn't my fault. It was just
Oh,
things were like working against me. Um,
yes.
and one of the other challenges is that it went undiagnosed for so long because I remember at like the 6 month or 6 week follow-up appointment, I was given the depression screening and I was doing really well at the time, but my symptoms showed up at like 5 months.
Mhm.
And at that point, I didn't get any more screening. Like it wasn't even on anyone's radar. And so I really hope that will change and that because I think, what you shared about it's important to screen for like that full year after. I don't know if that's fully recognized by pediatricians and PCPs and OBGYNs. Like hopefully now that's been 6 years, 6 years ago, I guess that my daughter was born. But anyway, yeah, thank you so much. This was, like I said, it just really was validating to me. So
Oh,
Yeah,
good. Thank you
that's
for your feedback,
important.
and I'm hopeful. I think that the more that we talk about it, and the more there's awareness about it, then the more that it is being caught, or you are seeing the providers, or even just having awareness yourself about, hey, actually, I've heard about this, and I do want to talk to somebody about this and to treat it. So I really appreciate you sharing your experience. Thank you.
yeah, of course. Thank you.
Thanks so much, Molly. We really appreciate your coming on
Oh,
today.
thank
And
you for having me.
your expertise is clear, and we love to have our audiences um, have such wonderful experts come and talk to us.
Awesome. Well, thank you so much for having me. I really appreciate it.
You bet. Next month, we're going to talk about nutrition, the importance to
Oh,
nutrition,
interesting.
mental health, right? And that'll be on October third Wednesday of the month, as our normal lunch and learns are, the 16th. So please join us then. Thanks, everyone, and thanks especially to you, Molly.
Thank you so much.
Bye-bye.